All right. Welcome, everybody. Thank you so much for joining us today for the Maryland Latinos Unidos collaborative session on effectively bridging the language gap among Latino communities. We know that this is a very timely discussion. It's a very much needed discussion as we work with our Latino communities, as we're expanding our services, as more things are going on. We always have to center back into how we can ensure that our communities are receiving access to services. So just want to thank you all for joining this session. Before we get started, I want to just acknowledge our funders. So this project is supported from the CDC National Center for State, Tribal, Local, and Territorial Public Health Infrastructure. And this is part of an opportunity through the National Network of Public Health Institutes to share CBO best practices and lessons learned during the COVID-19 pandemic. So we want to just thank our funders for giving us this opportunity to do this today with you. Great. Just as before we move on to the agenda, I want to make sure that we just walk through some of our housekeeping items today. This is going to be a pretty hefty conversation. This is also being recorded, but just please ensure to keep your line on mute during the presentation. We have our MLU staff, Walter Saba, who can support with any technical assistance as needed. But in the meantime, just to reduce background noise, if you can please keep your line on mute, but you may come off mute once we move into our discussion. We would love to see your beautiful faces. Yes, absolutely. So we would love to see your faces, but only if you are in an environment to do so. We understand oftentimes we're not in an environment to do so, but if you can, we'd love to see you. If you have any questions or if you need any assistance, please feel free to raise your hand. Our team here at MLU can provide any tech assistance. And as you can see that this session is being recorded. So just so you know that this is going to be posted onto our Maryland Latinos Unidos YouTube link once the recording is made available. And we'll also be sending the slides along with the recording to all of our registered attendees. I just want to mention, I know, Vero, you mentioned this earlier, but we actually have about 75 people registered for today's session. So we have a really great audience for today to learn about how we can effectively bridge these gaps within our Latino communities. I know many folks are just joining us, but in the meantime, before I move into the agenda, if you can please put your name, your organization, and your role in the chat, just so we can get to know who's here for today and learn where you're coming from. And we're excited to meet you and also see you again if we've collaborated before. So just a bit of introduction. We're going to walk through who MLU is, what the goals and objectives are. We're going to have about three poll questions and just one extended poll question around how you learned about this event. We're going to move into the content around language access needs, what the problem is, what the issues, what we're seeing in the community around Latino and Hispanic populations. We're also going to have a quick case study on one of MLU's lessons learned and best practices during the COVID-19 pandemic. And then what we're probably all here for is to hear from our amazing partners and our incredible leaders in the community on strategies to improve language access in the field. So today you're going to be hearing from Veronica Kuhl, founder and Hispanic strategist from Kuhl & Associates. You see her waving her hand. And then we also have Jocelyn Rodriguez, who is founder of Coaching Salud Holística. And then we're going to please keep your questions written down if you have a pen and paper, if that's how you like to write things down. We will be taking questions at the end, so you don't forget your question. Feel free to write it down. You can also put it in the chat. We're going to be collecting them as we go, and we're going to address them toward the end of the session. But if you have any questions that you'd like to ask, please reserve them for the end. All right, so who is Maryland Latinos Unidos? So MLU was actually founded by our amazing founder here, Veronica Kuhl, during 2020, when there was a significant need for Latino support during the COVID-19 pandemic. We are an organization where we convene a collective of statewide networks of Latino leaders and non-Latino leaders to increase the support for our Latino immigrant communities and populations in the state of Maryland. Our mission is to call attention to the disparities and inequities faced by Latino and immigrant communities and finding solutions to address these problems with coordinated action. And here's who we are. So this is the project staff for this work. So my name is Velázquez-Umaña. I am this is an old title of mine. I apologize for not updating that, but I'm the Senior Manager of Operations and Innovation. We also have Dra. Gabriela Lemos, who is the Executive Director of Maryland Latinos Unidos, Walter Saba, who is our Senior Program Manager of Health Equity Programs, and Kemi Ortiz-Tai, who is our Community Health Organizer on staff. Great. So what the goals and objectives for today is for you all to learn effective strategies to bridge those language gaps between our Latino populations and public health systems. There are so many strategies, there are so many ways. We know there's not a one size fits all. This is going to give you a diversity of strategies that we have utilized here at MLU, along with our leaders and speakers from the field doing this on a day-to-day basis. So you're going to get some toolbox, some toolkit actions, some more tools in your toolbox to be able to implement strategies to really bridge that gap within Latino community around language access. And really, we hope that you learn around what language access is beyond translation. We know Google Translate isn't the way to support our community. It's really encompassing cultural sensitivity and awareness of the diverse needs of our community, of the Latino community, also recognizing the impact of what inadequate language access, how that plays a role in our health outcomes and healthcare disparities within the Latino community. And again, really key here, the real world strategies in the field to increase your language capacity within your respective organization, including training staff, interpreters, employing culturally competent communication, etc. So we're going to kick off with a poll question. We're going to give you a few minutes to do this. So let's see. Relaunch. There we go. So you should see a poll now on your screen. So we have 4 questions here. The first question is, on a scale from 1 to 5, how confident are you that your organization is meeting the needs of the Latino community? The second question is, does your organization offer interpretation and/or language translation for Spanish speakers? The third question is, do you feel that your organization has the capacity to provide language access and/or interpretation for Spanish speakers? And this isn't on the screen, but it is in the poll, is how did you learn about this event? We would love to hear from you how you got here today. So would love to hear from you how you learned about this event that's hosted by MLU. So we'll just give you about 2 minutes to finish this poll. We have about, let's see, we have about 15 folks participating, so 45% of our audience is participating right now, but want to give you all an opportunity to do that. So we'll give about another minute or so. Let's get that 100% participation, y'all. All right, just another 30 seconds. All right. So I hope you all are able to see the results in front of you, but it's so great to see how many organizations are able to offer language services. It's also really great to see that there is some work to be done on your confidence to ensure that you're meeting the needs of our Latino community. And then it looks like a lot of folks have capacity to provide language access and interpretation for our Spanish speakers. Great, thank you so much for participating in this poll. So let's get right into it. Let's get into the content for today. So in the United States, our Latinos have grown. There are 63.7 million Hispanic Latinos living in the United States as of July 2022. This is, according to the US Census Bureau, one of the largest ethnic minorities in the United States, making up 19.1% of the total population here in the US. However, when we use the word Latinos, Hispanic Latinos, they really bucket us into these, into this monolith. And Latinos and Hispanics are a mosaic of identities. We do not come from one place. And so the US Census Bureau really breaks down where our Latinos are coming from. As you can see, a large percentage is from Mexico, a large percentage is from other Hispanic. We have a really great diversity from South America, Ecuador, Central America, Dominican Republic, Puerto Rico. So there's so many Latinos and Hispanics in this country, but oftentimes we forget, or organizations or folks forget, that we are not a monolith. We come from various places. Just because we speak Spanish, it doesn't mean that what you're saying to us resonates within our culture and our roots. And so we need to think about Hispanic Latinos in a mosaic of identities, and what that means for them, and what that means about tailoring your communication, tailoring your healthcare services, tailoring your programs to the different cultures that are within our Hispanic Latino community. And so in Maryland, from a Maryland 2023 US Census Bureau report, there are over 700,000 Hispanic Latinos in Maryland, making about 11.8% of the total population. And there has been a 55.1% increase of Hispanic Latinos in Maryland in 10 years. So we are a growing community in Maryland, and it really showcases why there is such a significant need of being able to provide our communities with access to services in their respective languages in a culturally mannered way, especially seeing that previous report from the US Census Bureau of where we're coming from, or where we're from, where our roots are, where our cultures are from. And so, again, the Migration Policy Institute also states that 25% of the population that's aged 5 and above speaks Spanish in Maryland. And so I learned Spanish. That was my first language. I didn't know English at first when I was going into school. We need to look at how many Spanish speakers there are in Maryland, because we need to understand how much of the resources and what support we need to provide within our own organizations to better serve our Spanish speakers. This is a large population within the state of Maryland. And so we need to really look towards being able to increase our language capacities in a culturally tailored way. So I'm going to get into law just a little bit. So the Civil Rights Act of 1964 requires any federal program that receives federal financial assistance, they need to take reasonable steps to make their programs and services accessible, especially to our communities that have limited English proficiency. The Federal Department of Health and Human Services and the court have applied this statute to protect the national origin of minorities who do not speak English well. Thus, recipients of federal funding must take these reasonable steps to ensure that people that have limited English proficiency have meaningful access to their programs and services. So this is a federal law that has been instated through the Civil Rights Act of 1964. So with this emerging community, with a lot of Spanish speakers in the state of Maryland, with a language access law within that's been embedded into our nation to provide these steps towards ensuring our communities have access to services within their respective languages, why are we still seeing gaps? Why are there still communities not having those access to those services in a language, in a way that they understand, in a way that they can feel empowered to understand and make those decisions for themselves, and what that looks like for their health outcomes? Well, let's take a look at workforce. While there's 19.1% of the United States who identify as Hispanic Latino, less than 7% of physicians are Hispanic Latino. This lack of representation in the delivery of healthcare has been shown to exacerbate health disparities, especially among our underrepresented groups, and is a significant barrier to the Hispanic Latino community achieving optimal health. And so the Pew Research Center actually surveyed our Hispanic communities, and 58% of Hispanic immigrants say they prefer to see a Spanish-speaking healthcare provider. So there's a wonderful quote here that really showcases the reason why they want to see a provider that speaks their language. It's easier to explain the discomfort and understand the indications. Although if you have an interpreter, it is not the same in my opinion. I feel more comfortable when my doctor speaks Spanish, and this was a quote from a Hispanic woman between the ages of 40 and 65, which really showcases the need of how providers and patients, if there is a language barrier, how can you build a trusting relationship with your provider or with your healthcare provider when they don't speak your language? So with this comes access to services. So having communities that have limited proficiency in English truly impacts their ability to obtain healthcare, and it also reduces their access to information in the media. We saw a huge amount of this during the COVID-19 pandemic, which we'll talk about in a little bit. But this creates a significant barrier between the information, between the provider, between their healthcare outcomes, their healthcare communication, if it's not being received in a way that they understand, especially in their language. And so what does that mean and what does that look like? So this is a quote from the University of Georgia. If you are linguistically isolated, you are very likely to be isolated socially, and we know social isolation contributes to mortality. At the University of Georgia, they did a study where they spoke with 1,100 Mexican Americans ages 65 and older in Arizona, California, Colorado, New Mexico. And they surveyed them between 1993 and 1994, and they did another follow-up between 2004 and 2005 to assess their healthcare outcomes, especially around communication. And what they saw was this community had worsened healthcare outcomes. They delayed their care with their provider. They missed health screenings for chronic diseases and cancer, which is super vital and what we're seeing as comorbidities within our Latino community. And they also saw that the language isolation was linked to poor mental health. So we see that this language barriers and not having somebody that speaks your language can truly impact their healthcare outcomes. And in the Nurse Journal, they also saw that many patients had difficulty with medication. 35% of patients, they experienced confusion about their medication. They didn't understand. They also suffered, about 16% of the patient population also suffered a bad reaction to their medication because they likely didn't receive the information in a way that they understood. Also, about 65% of patients who did not speak the local language experienced barriers to healthcare, including 20% who did not seek healthcare services because they were scared. They feared that from their provider that they might have a misunderstanding around their symptoms, or they may feel disempowered to communicate about what they might be feeling. And this also leads to adverse health events. Language barriers led to detectable physical harm in just over 49% of patients, where in nearly 47% of patients also experienced moderate temporary harm. So as you can see, when there are language barriers, especially within our Spanish-speaking and Latino community that is emerging in Maryland, these are some of the healthcare disparities that they can face when they don't have access to somebody that they can talk to in their respective language. And so during COVID-19, we saw a lot of that. And that's how MLU was born, because we saw that there was a need. Our Hispanic and Latino communities were being left behind. So back in 2021, the COVID-19 and health disparities report came out in Maryland, where they saw, if you can see here in this graph, the gray line is our Hispanic community over time in terms of confirmed death rates due to COVID-19. So they saw the Hispanic daily rate was dramatically higher than any other. And it rose much higher and it peaked much later during the COVID-19 pandemic. And this epidemic really penetrated our community, our Hispanic and Latino community, in terms of rates of cases, also because they had previously, prior to the pandemic, also continued to face health disparities and lack of access to care in their respective language, where they had complex conditions and comorbidities that also exacerbated when they also, if they got COVID-19. So a lot of this we saw during the COVID-19 pandemic, which caused our Latinos and Hispanics to be truly impacted by COVID-19, which is why we saw a huge death rate and increased rates of COVID-19 within our community. Oh, sorry about that. All right. So what does that mean in terms of our social drivers of health? So our communities who are racial minorities and have limited English proficiency, studies found that their COVID-19 incidence rose by 21.7%, and their mortality rate was also 21.7%. And again, as I mentioned before, this was as a result of previous ongoing comorbidities, not just around their health conditions, but around their social drivers of health that impacted their education access and quality, their healthcare quality, where they lived, their social and community context, and their economic stability. So as a result of this, and the presence of these comorbidities, living in crowded housing, having lack of access to public transportation, in addition to lack of healthcare quality because they probably didn't receive healthcare in their respective language or didn't have access to somebody due to insurance and other, it's just so many layers. And there's just not one thing that we can talk about. It's just so many layers of what truly impacted our Hispanic Latino community during COVID-19. But when you have limited English proficiency, that truly increases your likelihood of obtaining COVID-19 due to lack of information, lack of healthcare access, lack of many things. And so we're seeing all of these things and what's happening within our community. And this is a huge, significant problem that even with federal law, even with having some sort of access, even with having interpreters, there just isn't a way where our communities can feel safe in the spaces they go to when they don't see somebody that speaks their language. And we have significant workforce challenges. We have our communities facing complex conditions. They are experiencing comorbidities due to injustices where they live, due to policies that are not meeting their needs. And so, again, I want to make sure that you all walk away with not how we can save the world, but how we can work towards taking immediate steps and making effective strategies to improve language access within our communities. And so what we're going to talk about next are some strategies that have been proven to work at a smaller scale that can work towards within your community. We understand all of our communities look different. We understand that each community have different resources. What you're going to hear next is a case study that we worked on at Maryland Latinos Unidos due to funding that we received from the Mid-Atlantic Latinx Vaccine Equity Coalition. And this was actually presented at the American Public Health Association as a best practice. And so we did a community-based public health response to improve child immunization rates within our Latino populations during the COVID-19 pandemic. We know COVID-19 was an issue. However, as I mentioned, there are so many layers that are impacting our Latino and Hispanic communities that oftentimes COVID-19 wasn't a priority. Their priority was putting food at the table, making sure their children were safe, getting access to primary care. Oftentimes, those were the critical points and priorities of our community. So what we were seeing during COVID-19 was overall nationwide, children were really behind on their regular child immunization rates because many communities were scared to go to their pediatrician. They didn't have access to a pediatrician, or they just arrived to the country and didn't have access to health insurance. And so in the local community in Silver Spring, there were two specific elementary schools that are Title I schools, where they had the highest farms rates. And if you don't know what farms are, it's a free and reduced lunch and meals within schools. So families have to apply to be able to get reduced lunch or free lunch based off of their income. So this is usually a criteria that is used to look at kind of what the income levels look like within the community or within respective schools. So in 20903, there are two schools, New Hampshire Estates and John Lillick, where they have two of the highest farms rates within the elementary schools in Montgomery County. And many parents were reporting that they had decrease in childhood vaccinations because within those two schools, they also had school-based health centers. However, during the COVID-19 pandemic, those school-based health centers closed. So once schools went virtual, those health centers were many children that didn't have access to health insurance, or they depended on free healthcare services because they provided sliding fee scales, or they provided at a lower cost. They didn't have access to their pediatrician, or they didn't have access to any healthcare provider throughout the entire COVID-19 pandemic when schools went virtual. So community members raised awareness in their local community, and especially to local elected officials, that this was a significant issue in their community. For many children, this is also a hotspot for recent migrants that are immigrating from their countries, where they didn't have access to a school-based health center. And so together, a community-based organization, CHEER, the Montgomery County Department of Health and Human Services, the Latino Health Initiative, and Casa Rubén Foundation, which is led by a Latina pediatrician, Doctora Peralta, we came together to create a local hub. It was just a one-time hub that was that we worked with our local elected officials to develop a stopgap, which means we wanted to, before the school-based health centers they were in process of being open, kids were not going with their childhood vaccinations. So we wanted to develop a stopgap around that. So what did that look like? So we worked together to create a pilot project where the CBO, which is CHEER in this case, we utilized our case management system and looked within zip codes of all of the children that we had in our system that were living in the surrounding zip codes and the schools that they would be designated to go to those specific schools. We had promotoras who spoke the language, who were oftentimes from the countries where many of the communities were coming from. And they were able to provide wraparound services, especially with communities that recently arrived to the United States. In just 2 days, our community health workers reached 150 families in 2 days. And so what we did is we implemented a training between the Latino Health Initiative, the pediatrician, this is completely Latino-led. Many of us are from Argentina, El Salvador, Guatemala, Ecuador, Puerto Rico. You know, we had a diversity of Latinos that were really spearheading this initiative. And we were trained, and we also trained our community health workers on what the immunization schedules looked like, what were the necessary documents and paperwork that were needed to make these visits within the clinic. And so we also did a lot of patient screening through the phone, and we were able to bring in those families. And so we implemented a strategy and a new kind of workflow within the office where we did phone calls and did case management, where we identified our communities. We also created that satellite office where we screened those patients and families to come in. We also had patients in the surrounding community who would come to the office for additional case management. And we were able to do case management screening through the patient questionnaires during the visit. And then we had the pediatrician who spoke Spanish. She also had her community health nurse who also spoke Spanish that provided that wraparound medical services where they did immunizations. They also helped the families complete school forms in preparation for schools opening up. And they were able to really provide a holistic a medical healthcare service, but also doing some primary physical triaging, because many of these communities, and especially the children, had not seen a provider during their journey here to the United States. And so the provider was able to also enter all of the immunization into the Maryland immunization record. So that way the community, the families, had immediate online access to that information and were able to print that out in their homes or wherever if they ever needed that for their record. And the local health department also supported us by donating masks and hand sanitizers, which was provided to every single patient so they can be prepared in advance of schools opening up and for their children to be safe during the COVID-19 pandemic. And so what did the results look like? So the children aged ranged from 0 to 5 to 6 to 10. We had a large population of children coming in from 11 to 15, and we had a few young adults. A few of them were uninsured. Many of them had care for kids, or they had access to Medicaid. We had families coming from El Salvador, from Honduras, Mexico, Guatemala, and Venezuela. And we had about half of the population that were born in the US and half of them weren't. All of them identified as Hispanic Latino, and a large proportion of the families had been in the US for 6 years or more, and a few of them had just recently arrived. And so what do those outcomes look like? 61 routine child immunizations were administered in 3 days. 14 out of 15 of children were under-immunized. I'm taking a quick pause there because that was insane. How many of those kids were under-immunized because they didn't have access to care. And 7 families were connected to health insurance, WIC, and to English classes. But again, we're tailoring this also to COVID-19. The parents, 2 parents also received their COVID-19 vaccines in the same location where their children were being seen. So not only did the children get medical attention, but so did their families. Because as our community, we don't look at just our communities in pieces. We look at our communities as families. And so the provider was also able to administer COVID-19 vaccines for the parents that needed it. And so a lot of them received physical examination, and 4 received consultations for other health conditions, such as mental health and dental. And again, all this information was entered into the data system. And so just before we move into our next spot here, but I just wanted to showcase that case study because it is an example of how our communities can come together, strategize, and implement a program to reach our communities where they are, to speak to communities in a language that they understand, be able to provide staff that can ensure that they are able to walk them through not just a medical system, but also ensuring that they have access to health services and that they can talk to somebody if they need help. As community health workers, and especially promotoras de salud, they can offer a really, really empathetic, tailored care. But also when you bring in providers that speak their language, you can get that result. You can see those outcomes of improved healthcare within our Latino community. So I've been doing a lot of talking, and I know you all are here to hear from our just incredible people that are here with us today. So I'm going to move into some quick introductions, and then I'm going to pass the torch over to Veronica. But we have 2 wonderful speakers today who have such a breadth of experience in providing access to language services within our community. So first, I'm going to introduce Veronica Kuhl, a Dominican-born Veronica, who founded Kuhl & Associates, LLC, to connect organizations to the Hispanic community, offering strategy, training, marketing, and public relations and language services. She published the first of its kind Hispanic Heritage Month Essential Toolkit to facilitate the acknowledgement and engagement of the Latino segment in the U.S. committed to empowering our community. She established the Latino Innovators Pitch to Scale, Latino Businesses Profitability, along with 2 Facebook groups, Yo Quiero Trabajar and Emprendedores Exitosos, that provide resources and opportunities for job seekers and entrepreneurs. Additionally, in response to the COVID-19 outbreak, Veronica co-founded Maryland Latinos Unidos, a nonpartisan statewide nonprofit to build capacity among Latino serving organizations. She also serves on the board of Maryland Latinos Unidos, Loyola University Board of Sponsored, MedStar Good Sam Hospital, Maryland Women's Caucus Foundation, and Maryland Association for Nonprofits. She's been recognized by First Lady Michelle Obama and is the proud recipient of various awards, including the Latina Style Entrepreneur of the Year, NFL Hispanic Heritage Leadership Award, Innovator of the Year, and U.S. Hispanic Chamber Corporate Leader of the Year. She lives near Baltimore in Carroll County with her 2 college-age kids, keeping busy with writing, reading, and donating fire trucks. Amazing. A round of applause for Veronica. And next, we have Jocelyn Rodriguez. Jocelyn Rodriguez is a dedicated advocate for holistic health and wellness with a Bachelor of Science in Exercise Science and a minor in Psychology and Health. Jocelyn's passion for promoting well-being led her to establish Coaching Salud Holística in March 2022. Currently pursuing a Master of Science in Health Science at Towson University, Jocelyn is committed to furthering her knowledge and expertise in the field. Throughout her career, Jocelyn has made significant contributions to community health in Maryland, with roles ranging from community health worker and organizer to case manager and health coach. She has tirelessly served diverse communities, particularly focusing on the needs of Latino and immigrant populations. Fluent in English and Spanish, Jocelyn effectively bridges language and cultural barriers to deliver impactful health education and advocacy. Jocelyn's dedication to professional development is evident in her extensive certifications, including lifestyle coaching, nutrition, mental health, first aid and CPR, childbirth education, diabetes self-management coaching, and diabetes prevention coaching, among others. With comprehensive skill set and a deep commitment to empowering individuals to lead healthier lives, Jocelyn continues to make a meaningful difference in her community through Coaching Salud Holística. So it is with just quite honor and privilege that I introduce these 2 leaders in the field, and I'm going to pass it over to Veronica. So Veronica, I'm going to stop sharing my screen and we can move on to your slides.
Awesome. Thank you, Kelly. You are fabulous. Very, very thorough. Can I get a thumbs up or a verbal that you guys can see my screen?
I can see your screen.
Very nice, very nice. So, you know, I have 10 minutes, and if you guys know me, I can speak for 12 hours on this topic. So I hunker down, and I gave you some very high-level highlights because I know this is the tip of the iceberg. But I just want to start with a reminder. A lot of the people that are on this meeting are English dominant or English speakers, so you're fluent. But what if you're overseas or you're traveling somewhere and you see translations like this? You know, apparently that's not what they say. They didn't say jump off a cliff. They didn't say kiss my kids. Of course they didn't. And even if we get local, we can't even read what doctors write. So I'm sharing this to kind of break the ice a little bit and just remind folks how very important language access is and how it shows up every day. So in the US, you don't recognize how different or how wrong or incorrectly the language shows up because you're not reading Spanish, you're not reading French, you're not reading Chinese as it would be, you know, in Thailand or in China. But in the United States, if we don't get it right, it is that difference between that one letter, that one sound, living or dying. It is that tremendously important. I don't want anyone to dismiss it. You know, you're in the US, you should speak English. In an ideal world, yes, you should assimilate, but it's not an ideal world. And the work we do today, the fantastic work that Kelly rolled out, is so, so important. Again, life and death. So when we dive a little bit into this, I want to ask you guys, whether you're a small nonprofit, large hospital, medical system, government agency, give me a thumbs up if you've ever asked these questions or you've received these questions. Let me get some thumbs up here on your little chat or comment. If you've ever asked any of, hey, what are they saying? Hey, can you quickly take a look at this document? Hey, what does this email say? Hey, can you do me a favor and just post this, translate it and post it in Facebook? Can you come here? What are they saying? They didn't fill out this form right. They didn't. Oh, can you sit next to them and you fill it out for them? Now, mind you, the person you're talking to most likely has another job. So imagine you going to the bathroom and you're walking and you get pulled aside. Come here, come here, come here. What are they saying? Come here, come here. What are they saying? It seems innocuous. It seems tiny. It's only 2 minutes. Come on, Veronica, be nice. It's only 2 minutes. But if it's one person, if I get it wrong, if I have something else waiting for me, I'm not doing my own job. I'm doing a disservice. I'm doing multiple things at once. It's not effective. It's not effective. And more importantly, it causes burnout. So my focus today, because we've heard about the importance of language access, Jocelyn will talk a lot about, training and different resources. Kelly touched on it with the case study. But I want to remind you that we have to remember this is about people before the operations kicks in. So before you have people running for the hills, the numbers are high. Latinos are growing at the fastest rate than any other segment. So we have 80% of the incoming workforce is Latino. The growth of the workforce in the US is Latino based. So if you don't take care of this incoming pool of workers, by the way, Latinos are 8 years younger than the average American. So if you get them in, you train them properly, they tend to stay with you longer. You don't want to burn them out because you hired me to do CNA work, phlebotomy, and you keep pulling me aside. So basic. Hire bilingual staff more. And I gave you some best practices in the corner. At the very minimum, when you post your jobs, at the very minimum, add the words bilingual or bicultural, preferably both. That immediately will change the search so that more bilingual people see your job postings. Doesn't cost anyone any money. The minute you write a job description, HR, hiring manager, add those words immediately. Number 2, make sure you recruit from Hispanic serving institutions. Just like there are predominantly Black colleges, HBCUs, they're Hispanic serving institutions. Maryland only has one, Montgomery College. So make them your best friend, show up to their events, sponsor their activities, so you can start tapping that incoming workforce. But as you're hiring talent, you got to do language testing. Guys, just because I say I speak Spanish, what level of Spanish do I speak? How do you know that I'm representing you appropriately and accurately? Do you want to trust Veronica with a 3rd grade Spanish level? I don't have that, by the way. I'm fluent properly. But do you want to trust me to represent your brand? Number 2, to protect your team, make sure that you have very clearly written job descriptions. Is my job phlebotomy, client, patient navigation, or am I translator, an interpreter? What is my job? Because you don't want to upset me in 6 months, I'm gone because you asked me to do so many things. So well-written job description. Be sure that you're paying a differential for language skills. We'll talk about that in a second. It is a skill. It is a skill. Requires certification, requires training, requires practice. It is a skill. It is not, oh yeah, she speaks Spanish, bring her up here to the front. It's a skill. Make sure that the workload is realistic. We have a dearth of talent. They're leaving because it is overwhelming. So if you're lucky enough to have recruited Latino talent, do not burn them out because you're burning them out, just because you're overwhelming them. I see it. I left my corporate job because I was doing 5 jobs. And then I visited another market and realized they had 5 different people making upwards of 60 to 100 grand per role for what I was doing in one. It's not fair. People see it. They're smart. They leave. So let me ask you a question. Give me a thumbs up or a comment if in your nonprofit, government agency area, there's a marketing or communications department or a function or people that do that work. Can I get a thumbs up? Thumbs up, thumbs up. Do you have people that do this for you? They write, they produce. Some of you do. Why do you have that? You all speak English. Why do you need someone else to write English for you? So pretty basic. We actually segment in English that skill of writing and communicating. It's an actual function people get paid to do. Language skills are the same. So if the mentality changes from the top of the house, from you guys, so that language is an everyday part of operations, then a lot of our issues will change. This is not a favor. So best practice right off the bat is know that language skills are not a favor. They're not a side gig. This is an actual function, certified interpretation, certified translation, properly trained bilingual personnel. It's an actual skill, should be part of your everyday operations. So how do you get started? First thing I tell all of my clients, audit your process. What is that patient journey like? What's that hiring journey like? And I'm talking to you from both aspects. The staffing, what's it like for a bilingual or a different person? French, Haitian Creole, Mandarin. What is it like for that journey as they come into your organization? What's it like for a patient, limited English proficiency, that is Chinese dominant, Spanish dominant, ASL dominant, doesn't even matter. What is that journey like? Have you done focus groups or surveys? What do they say about you? How do they perceive you? You need a baseline. And it can't be anecdotes. It can't be, I heard people say we're okay. Well, my boss says we're all right. There needs to be a formal process. It doesn't have to be expensive. It can be as small as a survey. It can be small as a social media, but you need to have a sense of what the community, what the needs are, what they're saying to you. And you, every time we work with a client and the big muckety mucks, we make them apply for their own jobs. And the minute they realize that it takes 45 minutes on their phone and there's glitches and it's not logical, they realize what that journey is like for someone with limited English proficiency, with less American experience. You know, I'm used to applying for a job back at home. I don't know what it's like here. So you have cultural barriers as well as digital, technical barriers and language barriers. So audit the process, number one. Number two, make sure you know who you're trying to reach. If you're reaching Veronica, cool. I am fully bilingual, fully acculturated. I don't process in Spanish. I process in English. So you talk to me in English in the outlets I use. But if you're trying to reach someone that's recently arrived, 3 years, 4 years, less acculturation, then they're Spanish dominant, then they're more grassroots, and they're more hand-holding, and there's more Facebook engagement. So who are you reaching? Because that will drive how you talk to them, what language, what staff, what skill sets. So if you don't know who you're serving, you're going to waste years of bringing in the wrong staff, implementing the wrong initiatives, advertising in the wrong place, advertising in the wrong language. You may not even need to do Spanish because your people speak English and they come with an interpreter or they know enough to get by. So know your audience. Do some community networking. Be with MLU. Be where Jocelyn is at her coaching events. Be with the community so that you understand the needs. From there, you can recruit. From there, you can promote your services. From there, you can get grants. So network with your community. And then make sure there's money in the budget for staffing, translators, interpreters, advertising, talent management, and coaching at a very minimum. Please do not expect that this growing Hispanic population and new workers are developing on their own. They're different. So you need to train them and onboard them differently. We do a lot of that because it's different. It's not status quo. And then internally, you prioritize equity, diversity, and inclusion genuinely. That should be a lens in which everything you do legitimately goes through, genuine and authentic. You authentically want to do better by people that are different than you. And by different, it can be military experience. It can be, I'm one of 3 siblings and you're one of 1. You're from a rural environment. I am from the deep South. So prioritizing and behaving in that way will change your outcomes, your culture. Now, everyday tactics, I'm saying it again, make sure there's money in your system. You shouldn't be seeking volunteers to do translations. You'll get low quality. You're going to have your brand represented by someone that isn't properly trained, and that's not sustainable. I'll help you once, maybe twice, but I'm not making your volunteer gig my job. I have to feed my family. So we can't keep asking low income folks that are generous to keep giving away their time. That's perpetuating poverty. It's unfair, not equitable. Translate only vital documents. Not everything needs to be translated. I am an official language service provider. I tell my clients, you don't need to do that page. That's not necessary. We can do just this. This is good enough. Invest in a professional translator. Please, no Chat GPT, no Google Translate. It's good enough if you're in a pinch, but it is not appropriate for everyday communication, especially when we're talking about life or death. That's not appropriate. The nuances are missed. I have example after example where people have been killed. I have doctors that handwrite discharge instructions on a napkin or tap the janitor. Can you tell them that they have to come back in 3 weeks? Sí, señora, que el doctor dijo que tiene que volver. Not when, not what, in a napkin, poorly written. So please, professional. Translation, interpretation needs to be professionally done. I will admit I'm fluent. I took a couple of medical interpretation tests just to be like, what are they talking about? How hard is it? I failed. I failed the medical interpreter exam because I did not know PhD level medical terminology. The doctor said, you have to let her know she has a XYZ blah, blah, blah hive. I don't know how to say that in Spanish. So I'm telling her, you have a scratch versus this is do or die. So make sure that if you're using interpreters, they are certified and trained. Their degrees of expertise. I'm not a PhD. None of, some of you are, but you're not practicing medicine. So imagine, how do you communicate that language, that nuance? That's why they need to be certified, so they're communicating effectively. And back to genuine equity, diversity, and inclusion. If we don't have that lens of the desire to be authentically helping and help supporting people, nothing you do will actually come out right. So real quickly, this is some of the stuff we've done just to show you the nuances. When we were working with the state of Maryland Department of Health on putting on the masks, this is the English campaign, masks on Maryland, masks on. So we went back and forth around what's the right term, cubreboca or mascarilla. And then the people in the background, look how subtle this is. These are our Latinos. Kids are playing soccer, not football. You have darker skinned mom holding her baby. You have a Latina graduate. You have a Latino worker. Again, it's not just the words, but the whole image so that the message gets through. The message gets through. And when we did this campaign, the messaging in English was to play, to show up for work. For us, it's, I got to work para avanzar, para mi familia. So even the cultural values translated. It wasn't just word for word, literally. Another quick example, so you know how important it is to provide language access, is the impact to your funding. We worked with a nonprofit organization to engage the community so the community would apply for grants. And it wasn't just translation. See how that's the bottom of the list? It's really every facet of how do we leverage the community to support the community. Community-led, community-informed, to the tune that $500,000 came back to the Latino community through these grassroots organizations. So there's real dollar implications to the work that we do, not just helping the community. So I'm giving you some resources here, the toolkit that Kelly mentioned, because there's so much data there that if you don't know where to start, you don't know what you're doing, that knowing your audience piece, you can start with this. So real fast, this is how you can get us. We're here through Kelly, through MLU. You can Google us. It's a very, very Latino name. I know, cool, very Latino, but intentionally left it as cool, my married name, because that's how diverse we are as a community. Kelly mentioned in the beginning, we're not monolith. I'm Dominican, I'm light-skinned, I speak fluent English and Spanish. We are Latino and we come in every single shade, so we shouldn't be bucketed. So please reach out to us with a very, very Spanish name of cool. And we're happy to help you with all of these pieces and working throughout how we can ensure we have health equity. So Kelly, thank you for having me.
Phenomenal. Thank you so much, Veronica, for all of your amazing work. And I mean, those images that you provided around the mask, I mean, that was just it. People can connect with it, both how they see themselves, they can emotionally connect with their day-to-day lives.
It's that subtlety. And if we're trying to reach people in what, 1.2 seconds, 2.2 seconds, you can't have it not look and feel like me. So you're wasting millions of dollars in a billboard and a campaign, and you're not even talking to me. So it does bubble down to, does it feel and sound like us?
Absolutely.
Thank
Absolutely. Thank you so much. So next we're going to hear from Jocelyn Rodriguez from Coaching Saludística. So Jocelyn, let me know. I'm going to go ahead and stop sharing my screen, and then you can go ahead and start sharing yours.
Okay, perfect. Thank you so much, Kelly, and thank you so much, Veronica. I think there was a lot of I was just like, yes, that is exactly what, I needed in terms of like my management to know in in my past. And that's actually a little bit about what I was going to be talking about today. So again, my name is Jocelyn Rodriguez, or Jocelyn Rodriguez. I'm the founder of Coaching Saludística. More than anything, we're going to be talking about, the language gaps that I've experienced and my colleagues as community health workers have experienced in healthcare settings. But a little bit about myself, my background is in exercise science, so very much into the kinesiology world and just being able to explain a lot of health promotion items and topics. I've worked as within the community health, public health field about 4 years now, but regarding health promotion, I've been working 10 years. And so currently I'm working on my master's. So hopefully I'll be able to learn some new skills along from, all my great mentors that are also connected here today to be able to bring more access for a lot of different things in our community. So that being said, a little bit about Coaching Saludística. We strive to empower underserved and underrepresented communities with holistic wellness and education, as well as community resource support. We are committed to fostering sustainable behavior change and promoting healthy living practices through personalized and culturally competent coaching in English and Spanish, and hopefully we'll be able to do this in other languages and for other cultures as well. We strive to equip individuals with the tools and knowledge needed to optimize their physical, mental, and emotional well-being, because we know that there's different aspects in terms of our wellness. It is not always just about going to the doctor and making sure that you have your prescription refilled or whatever. We really do try to look at the person as all the different domains of wellness that they have. So a little bit about what you can expect in terms of what I'll be covering is just a recap about what community health workers are, just in case you aren't familiar with that, as well as, what does the healthcare setting look like regarding community health workers, as well as the challenges that I experienced, as well as my teammates experienced when we were working at the hospital and also clinic that I used to work at, as well as the efforts made within that team of community health workers in that healthcare setting to be able to bridge the gap of language access in the hospital and taking the experience into the community. So I'll be wrapping up my section in terms of how I've been able to take that experience within those hospital and clinical settings and be able to make sure that we're providing, boots on the ground work to be able to better improve the language access and healthcare access in the community. And so again, this is not as specific to, one specific hospital. This is something that happens very often with community health workers working in healthcare settings, whether that's a clinic, hospital, or whatever it is. So, but I'll be talking a lot about the experience that I had with my teammates. So just to recap, community health workers, they're frontline public health workers who are trusted members of the community, and they share either ethnicity, language, socioeconomic status, life experiences with community members. They serve as the bridge between healthcare providers and the community, delivering culturally appropriate health education, outreach, and support to promote health equity, as well as access to healthcare services. So a lot of the roles that community health workers can have can vary based on what team they're in, or also can vary about where they're working. So for example, the work community health workers do in public health settings or schools or whatever it is may look very different to those working in hospitals and also those working in clinics. But when we're talking about the role of community health workers in hospitals, we're talking about these are individuals who are involved in patient advocacy, health education, cultural mediation, care coordination, social support, crisis intervention, and health surveillance. And the department really that I worked in was the outpatient department, where we had community health workers along with case managers. But the community health workers, our mission overall was to lower the probability of a patient being readmitted to the hospital. So although the community health workers, and I think till this day, this is something that happens in Maryland, although there is no, I guess you could say, Medicaid reimbursement or insurance reimbursement for having community health workers in hospitals, the community health workers do help save a lot of the money that hospitals spend on patients who are readmitting. And so, okay. So specifically the departments that community health workers will work in, and social workers as case managers, all of those that work in some type of social service and increasing access and equity is going to be the case management, care coordination, population health. It has a million different names, just as community health workers have many different names. But the goal of these departments is to be able to improve care coordination and collaboration among healthcare providers within the hospital and across the continuum of care. So as outpatient community health workers, our focus was to be able to make sure that from leaving the hospital that day number one of, going back home, that they had everything that they needed, whether that was medical supplies, that was understanding what, the providers asked them to do. It would be also making sure that they have a primary care physician, a whole wide of different things. Okay, so some of the challenges that at least my team and myself experience regarding, when we're talking about language access and the lack of it in the clinical setting was, for starters, limited number of Spanish-speaking interpreters who were overworked. I remember especially during the pandemic, I was actually working, I was spread thin between two hospitals. One was the COVID hospital that I was working with in the Tacoma Park area, and the other one was in that White Oak area. And so the interpreters that we had, especially at this White Oak area, during the pandemic, there was only two. As you all know, it was a crisis, especially, crisis of like people panicking, people getting sick, people getting worse. And only having two interpreters was not enough. When we're talking about that, we have hundreds of people who are in the hospital and the hospitals especially located in areas where there's a high immigrant population that are Spanish speakers. And so the interpreters were not always available. It was like we would always see them one side of the building to another side because they were running around. And so that was very much like an issue, because then that caused, those who were bilingual to have to step in. And like Veronica mentioned, our level of Spanish might be very different. There was a lot of examples where, we'd had the one social worker at that time who spoke Spanish, she was pressured into interpreting, and she had to interpret basically what type of surgery was going to be done, to the point where, she did make a mistake. She said the wrong organ when she was interpreting. And that just shows, of how important it is to not only have the appropriate staff, but also to have staff that is bilingual trained, if you do put them in those type of settings. But her role, end of the day, was not to be an interpreter. It was to be a case manager. And so little to no inpatient and outpatient case managers who spoke Spanish. Like I said, there was only one case managers between the two hospitals that I worked with that spoke Spanish, and she was absolutely spread thin. And then we saw that there was either no materials translated into Spanish. So especially those revolving diabetes care management. So a lot of the times community health workers were pressured into translating that material into Spanish. And it was very, it was overall scary. And like, I know I was very nervous doing that because, one, I knew I wasn't qualified to do that. Two, it was, if I mistranslate one thing of this person's treatment plan, that is life or death. And so there was not enough materials being available in Spanish. And then the other thing is also, the patient advocates. Many people don't even realize that they can ask for interpreters. And then when we have interpreters come into the space, they, of the interpreters, when we're talking about them, sometimes they'll have specific dialects, because, just like I say, like there's different dialects in English. Sometimes we don't understand maybe somebody from, or the terminology or whatever it is from somebody from maybe Jamaica versus Australia and versus the US, right? Similars in Spanish. So we'll have medical interpreters who sometimes would be brought in through the phone line because, although we had the two in-person interpreters, we also had the phone line. And many of the times the providers and the case managers did not want to use that, but the times that they did, these were interpreters who spoke like Spain from Spanish from Spain. And so, or it was like a type of Spanish that was a completely different dialect. And then that doesn't even take into consideration that, sometimes there was what I would say some type of like unconscious bias where just because somebody looked Latino or they put on their papers that they were from Guatemala, for example. And then when we have the interpreters come in or we have the community health workers come in and we're trying to, bridge that or have that rapport with them and speak to them in Spanish, it turns out they don't even speak Spanish. They speak one of like they were Mayan. And so they spoke, I think, Mum. And so there was a lot of that happened as well. Patient advocates, those are the individuals who are there to advocate for the patient regarding, whatever procedure or just feeling that they need some type of support. And those patient advocates were not always bilingual in Spanish as well. So a lot of that caused a wide range of different things. So for example, it caused high readmissions and long lengths of stay, which we know that's a big issue and that's a big thing that hospitals, especially in that population health space, focus on. Delayed patient care, fear and mistrust of healthcare providers. There was HIPAA violations, and that's something that I know happens, not just again, like in these two hospitals that I'm referring to, but like across the board in medical settings, because then sometimes it's like you get somebody, you tap on somebody's shoulder, hey, can you translate? That is a HIPAA violation because they don't work there at the hospital to be able to manage that person's care. Fear of deportation, that was a big thing. It's something that still sticks with me till this day, where we didn't have a patient advocate for this one individual who spoke Spanish. He was from El Salvador, and he did not want to go back to El Salvador. And the reason that the conversation of deportation came into play was because he had a wide range of different needs. Like he needed to be in some type of rehabilitation, and he had nobody here in the US to be able to support him. He was uninsured, so none of the rehab centers were able to take him. The case managers kept him, I think, for almost like 3 months there. As community health workers, we had no idea what to do. They got that, what is it called? The consulate, the embassy, and everybody involved regarding this individual's, case. And the result of that was that this individual was deported. In reality, was, that's probably not the language that they use, but, calling it for what it really was, is that this person was sent against their will back to El Salvador. And he did not want to go for a wide range of reasons. One, he didn't have the support over there either. Second was that the reason he came to this country was to flee from gangs. And he said that if you deport me back to El Salvador, they're going to kill me. And it was really unfortunate because there was no patient advocate who spoke Spanish who could really intervene for him. As community health workers, we were spread out so thin, so we couldn't even keep up with, what was happening hour by hour with this person's case. And that's something that that experience I know spread throughout the community, that some people now say oh, well, if you go to the hospital, they might send you back to your country, because that is something that happened. Burnout of bilingual staff, high turnover rates, longer wait times in emergency room. And then also a lot of the issues that we see, again, because a lot of the information is not provided in Spanish, we saw high rates of sepsis amongst the Latino patients, as well as diabetes related complications. And so a lot of the things that as community health workers, we were a very small group of community health workers, probably I think at this one location I'm referring to, we were probably technically 2. Because we had our sister hospital that had some community health workers, but of course, everybody's in their own space. So as community health workers, a lot of the things that we experienced was, again, we weren't able to then do our job, which was to provide wraparound services and support to applying to local and federal programs, because we were, on the floor translating, we were interpreting, we were trying to build that rapport between provider and patient. We were a lot of, in our team, I know now, many have felt burnt out. Mental health was severely impacted by the community health workers and the staff who were bilingual. It was very apparent that, our mental health was very poor at that time. There was a high turnover rate. Pressured into that medical interpretation, again, leads to the confusion of treatment plan and also roles. Because then we have, that's the point of having a case manager. They're the ones who are working with the providers to be able to think of like how they're going to, create that treatment plan. But then we have community health workers being brought into inpatient settings when in reality, we're supposed to be in that outpatient setting. Then we see time constraints to be able to complete tasks. The work does not stop. We're constantly being asked to do X, Y, and Z, to volunteer our time to be able to translate, but that doesn't stop that fact that I have to complete X amount of, close X amount of cases by the end of the week. There was a lot of shared experience that we had little to no management support due to lack of cultural competency from leadership, time on their hand, and a couple other things like that. So as community health workers, what some of the things that we try to be able to alleviate and solve a lot of these issues was to be able to ourselves, we started studying, medical terminology, just trying to figure out like how do we even explain if in case we get brought into a discussion about, how to explain either signs or symptoms or surgery. We had to learn, and that still is, although that is great skills to have for ourselves, it wasn't our role to be medical interpreters. Identify needs. We had to work in a way that was very specific to the Spanish-speaking population. So, for example, we tried our very best to capture them from the emergency room or the emergency department before they even went upstairs to be seen by a provider to receive further treatment. So, for example, a lot of the individuals that I had that were Spanish-speaking, uninsured, usually that was the combination that we always saw. We would always ask case management to just submit a referral to us, and we'll just start working with them from inpatient all the way to outpatient, even though our role was not that. Our role was to focus when they actually left as opposed to when they came in. Patient advocacy, we had to teach patients, and we asked them to even spread that information. This is how you ask for an interpreter. This is a line outside of the hospital that you can call for a medical interpreter. We had to teach individuals about their rights, and also just letting them know that, if they don't feel seen or heard, even after having some type of medical interpreter, that, they could ask for different type of like providers. So we had to do a lot of patient advocacy, and also do a lot of cultural competency education to providers and case managers, because many of them did not understand that the needs were going to be very different, that the decisions regarding their health was going to be very different compared to those that are not Latino. Latino is, we have individuals who are going to ask maybe their wife, their mom or sister, whoever, like, hey, what do you think I should do? Should I go through with the surgery or should I not? And so that was something that we had to do as community health worker, where again, although that is great, that did take away a lot of our, take us away from our work. Another thing is that end of the day, we did not have the management who took the time to learn more about, Latino competency. And that was not something that was implemented across all departments. And so it was a never losing battle. It was a endless battle. Also, then we had to collaborate, with the financial aid department and who submitted emergency Medicaid applications to better understand, what that process looked like. So that way we then can go back to translate it to this Spanish-speaking patients. So I share all of this just so you can understand a little bit about, what is actually happening versus what is maybe being reported out by clinics and hospitals. This is, again, my experience with my team at that time. And, some of the things that we very much saw that we needed was, to provide language access services and have the accountability for providers and case managers to use it. that is very important. Hiring additional bilingual staff who work in these settings already. So whether they are nurses, whether they're surgeons, whether they are front desk, those are the individuals that we need to have more of, especially in this healthcare setting. Translate essential materials, having that information in Spanish, where let's say if a community health worker, we don't have to chase after where it is like, hey, can you translate this? Or like we have to translate it ourselves. So because that is a delayed care. Cultural competency training for all departments and healthcare settings, not just those who are interacting outside of the clinic or outside of the hospital, but within, because that, I think I know hospitals, for example, strive for having great patient experience. Part of that does involve having providers be trained in cultural competency. Then we have the health literacy initiatives, implementing the health literacy initiatives that focus on improving health literacy skills among Spanish-speaking patients. So including providing clear and simple health information in Spanish and offering educational workshops and resources. And then overall policy advocacy, making sure that there's accountability for those who do not provide this type of access, appropriate access for its patients or its community members, and be able to regulate funding into the language service access and requirements that there should be, as well as incentives for healthcare organizations to prioritize diversity and inclusion efforts. So I know that's a lot, but taking all of that experience, I've been able to take my experience from hospitals, from clinics, and also from other organizations. And that's actually how Coaching Salud Holística came about. A lot of the work that we're doing, for example, is focused on that grassroots. So working out in the field before they even get to that healthcare setting, because we know that there is a delayed amount of time of when we have Spanish speakers or newcomers that are coming into the country, from when they first arrive to get to even see a primary care doctor. That could be years, that it takes for them to be able to see that. So we've been able to think of that approach of like, how can we better serve the patients that are Spanish speakers in hospitals? And a lot of the work that we do is through professional development training. So we do some cultural competency training. We do also case management training. So training staff of different organizations, including schools, nonprofits, local government, on how do you appropriately handle cases when we're talking about Latinos, right? And how do you educate them about this? And then doing a wide range of different workshops, we're not only talking about health promotion, but also what are the resources to accessing healthcare revolving that topic. So for example, talking about rehabilitation centers for individuals who have who misuse or abuse of drugs. We do a wide range of workshops where it's like, how do you access healthcare resources in Prince George's County? How do you access healthcare resources in Maryland? We do a lot of that, so that way we can see it overall an impact on, the Spanish-speaking community. And so projected, this is just some information about, what we did last year versus what we're doing this year based on the projects we currently have. We're scheduled more or less to train about 500 people in a wide range of different things, whether that is in health equity, health literacy, case management, whatever that may be. For this year, we're expected to have taught a wide range of different workshops regarding resources and health to at least about 2,000 people, especially in that Prince George's area, and providing case management assistance to about 500 as of right now. These numbers might change. If anything, they might change to more people that will be assisting in our company. We are a for-profit consulting company, so we are here to provide either whether it's professional development trainings or direct services to the community. And we hope that long-term, all of these resources and education that we're giving to either staff or to community members, it becomes common knowledge where, if someone is uninsured and they need dialysis, it's common knowledge what is the process, that they have to go to the hospital and they have to, fill out emergency Medicaid. That's our goal. We want it to be common knowledge, but we also need the support of, healthcare settings, local health departments, so that way there is accountability and also the support to be able to bridge and increase language access within these settings. So I will stop talking, but I want to thank everybody. If you want to definitely pick my brain, I have different, experiences that I would love to share and just to see how we can definitely support one another. But thank you so much, Kelly, and I'll give it back to you.
Oh my gosh, that was absolutely amazing. And really thinking through, I loved your slide around what the gaps were and how some recommendations that folks can walk away with on how to improve their services within their organizations, taking into consideration. So I know we have about 7 minutes left on the clock. I want to make sure that we give this space for you all to be able to ask your questions. Are there anything that you noticed in the conversation? Is there something that you wrote down while everyone was talking? So the floor is to anyone. You feel free to either come off mute, or if you want to raise your hand, the floor is open to everyone in the audience. Any questions for myself or our panelists? You can also put your question in the chat if you are unable to come off mute. Any questions?
I think they're processing the amount of information. It's a lot. It's a lot.
Well, Kelly, maybe I can start with one question. Well, first of all, thank you, Kelly, Jocelyn, and Veronica for these great presentations. Really outstanding. I have just a very kind of simple question, although the answer may not be that simple. Is that after all what we have heard from you guys, ladies, after all the statistics that you have shared with us, I mean, what needs to be done in terms of health policy to overcome this situation? I mean, where to start?
Yeah, I'm happy to take it on and then pass it along to my colleagues here. But there's a Civil Rights Act, right? There is federal policy around language access, but we're still seeing these gaps. We're still seeing, I mean, Jocelyn and Veronica just explained it, like the gaps are still there, right? So what is not happening from the federal policy side to state policy side that is not holding these entities accountable to provide quality care? So my perspective is there needs to be more of an understanding and looking within internally of what are the capacities of these organizations, what are they doing to really bridge these gaps, and how are they doing it? I just don't think there isn't enough accountability from the policy side to be able to hold these organizations accountable when they're not providing this type of service. I mean, Jocelyn explained it in the hospital setting, the fact that she was pulled in for that to be able to do that. Why is nobody talking about that? Hospitals make a lot of money. Like, how are they not providing these services? So that's kind of my take on it. But happy to open the floor to, I don't know if Jocelyn and Veronica want to add to that as well.
I mean, it goes back to status quo. If we all accept it, if it is what it is, it is what it is. So, as a community, we allow to not be served. We don't have our own resources. So I think that the very complicated answer is we have to do the work. Advocacy happens at the state level with the community leaders and the legislators, but also at the grassroots level where people demand it. So if you're sitting there knowing that it's a right, then don't leave. Don't tolerate being put off, or don't tolerate having your 7-year-old be your interpreter. So, and we, you guys have heard me say this before, we have to stop working for free. So part of the problem is we are a people, most of us, if you're in healthcare, you care for people, you want to do good. So you're going to try to do it any way you can. That just keeps compounding the problem because Veronica volunteered Saturday. Oh, we can ask her again. And I'm nice, so I keep going. You have a slew of people that do side work for free. So the organizations never put it in the budget. So since you don't have a need for it, you're not soliciting grants, you're not looking for funding, you're not looking for appropriations. So it's perpetuated. So, Maryland, I said this before, is about 30, 40 years behind, New York, California. because they've been organized and funded longer. So I think we need to just stop. We need to stop politely. I'm not saying the world ends, it's not a strike, but we need to ask for what our rights are. And if you see an issue, slow down a little bit to put in the request to say, hey, I just pinch hit it right here. We need interpreters here. I can't work 24 hours a day. So it's bigger. It's way bigger than advocacy. And, you know, everybody's hands are tied and you want to do good. But how do you do good if you don't have funding? Chicken and the egg.
Yeah.
Thank you
I
very
think-
much, Veronica. Yes, Jocelyn.
Yeah, no, I was just going to emphasize, yeah, I absolutely agree, you know, with my colleagues here. And I think that more than anything, I can definitely speak for myself where I know at least myself and my teammates, we needed someone, we couldn't get it from management to teach us, you know, what our rights were, because a wide range of different reasons why we didn't have that support, but like having that type of like support, and I think Maryland Latinos Unidos does a great job about that, is like, you know, teaching, especially community health workers, you know, what are their rights are, you know, as staff, you know, what are the
Right.
you know, ways that they can feel empowered, because sometimes I can tell you, you know, I think a lot of us, it was like, we have all of these medical providers, we have management, we have supervisor who are pressuring us to translate. And it's like, if you don't do this, you're fired, you know, and it's like having that
So,
type of like awareness.
Perhaps,
Right.
Jocelyn, not to interrupt you, Kelly, can we take this away as an action item that perhaps we can do some kind of takeaway to educate our community, our members, the mainstream, non-Latino, the mainstream, so they understand what is normal and standard? Because a mainstream English speaker, supervisor, may not know. Like if I know you design, I'll hit you up. Hey, can you design this real quick? I'm not thinking that's not side of your job, so part of your job. So
Yeah.
let's MLU take that on. If we can have a course on a gear towards your audience, know your audience, to the mainstream hiring managers, supervisors, medical, whoever oversees providers. So they understand this is not part of everyday work.
Right.
Because maybe they don't know. And that's a burden that you have a very, very subservient culture. We as women in Latino cultures were raised to be subservient, don't talk, don't ask. And that's predominantly who you're seeing in healthcare roles, lower skill entry-level positions. So they're not going to ask you. They're not going to say, I'm not supposed to be doing that. They'll just keep trucking until they quit and you burn them out. So I know we're over time, so I'll stop talking because we can talk for hours on this.
I did see Tanya come off mute. Tanya, do you have a quick question before we close out?
Yes, actually, it's just not a question, it's in a statement. Well, I'm a community worker, but I have different positions, an immigration advocate, activist, and I have seen the huge need to keep all hospital accountable. Like you mentioned, they make a lot of money, but they don't actually have Spanish speaking staff. They not even know the community. All depends where the hospital is located. And there's a huge portion of migrants at the community with different language, and the language access is not accurate, you know. And I have seen many clients, they actually, you know, the doctors have sent them home with English instructions. And I'm like, and then I have to jump in and then, you know, also reach out to the hospital and make them accountable. They do have caseworkers. They do have the money actually to hire, you know, Spanish speaking or any other second language speaking
Hold them
staff.
accountable. We have to hold people accountable.
Absolutely.
And also, you know, like I've been training, educating the community that they have to right to ask them before they leave the hospital to speak with a case worker who speaks Spanish.
Yep. Yeah, no, thank you so much, Tanya, for your statement. I think that's so important that we have this ongoing conversation. I mean, this is an hour and a half of us, you know, having these conversations, showing these strategies, talking about best practices, but there is definitely a significant need to really think through leadership, like who is making these decisions, how we can ensure that our communities are being served and that there's no mismanagement, that our communities are being supported. But I know we're over time and I see many people are jumping off. So I just want to make sure that we thank our speakers, Jocelyn and Veronica, thank you both so much for your expertise, for sharing these tools for all of our audience here today. These slides and the recording will be shared once the recording is available on a YouTube link, but please stay connected with us, with Maryland Latinos Unidos. This is our website. Follow us on Instagram and X. I keep going to Twitter, but and on Facebook. So again, thank you all so much, and thank you for joining for today. We'll see you next time. Thank you.
Bye. Thank you.